Afternoon, my name is Carlos Rivera, and I am a research fellow for the surgery department at Cleveland Clinic, Florida. Before I start, I would like to thank the Society for this opportunity and to my mentors, Dr. Rosenthal, Dr. Lomenzo, and Dr. Shamsin. Today, I will be presenting the correlation between reduction of renal cortex volume and improvement in the estimated GFR after bariatric surgery. Nothing to disclose. One of the most common comorbid conditions associated with obesity is hypertension, which is a major risk factor for chronic kidney disease, stroke, myocardial infarction, and heart failure. The renal parenchymal volume has been regarded as a potential indicator of the functional residual capacity of the kidney. The renal volume may become an important tool for the clinical evaluation of renal diseases. Hemodynamic changes in obesity predispose to future organ damage, specifically renal hemodynamics. Before nephron injury, obesity causes an obesity-induced glomerular hyperfiltration similar to the observed in diabetes. One of the potential mechanisms of alteration in the renal hemodynamics in patients with increased BMI lies on the increased volume of fat located at the renal sinus and perirenal. This might result in compression of the thin loop of Henle and basal recta of the renal medulla. Such compression would initially result in a reduction in tubular flow rate, increased fractional sodium reabsorption. The reduction in sodium concentration would in turn cause an increase in renal blood flow, glomerular filtration rate, and stimulation of the renin secretion. As the kidney are surrounded by a tight capsule, expansion of this organ due to fat infiltration may contribute to intrarenal tissue pressure. External renal compression due to excessive visceral fat may also occur. Another mechanism that needs to be taken in account is lipotoxicity. The complex pathophysiology of obesity-induced hypertension continues to be investigated, but considerable evidence from studies indicates that major role of renal compression due to excessive renal sinus fat and visceral abdominal tissue squeezing the kidneys, leading to an activation of the renin-angiotensin aldosterone system, which mediates an increased renal sodium reabsorption that changes the renal hemodynamics. Therefore, it seems important to compare renal volume with the renal function and other clinical parameters. Our methods, we conducted a retrospective study in patients who underwent bariatric surgery between the years 2011 and 2018 in our institution. Patients that were eligible for our inclusion criteria were patients with obesity and without kidney disease documented. In those patients, we measured during the arterial phase of the CT scan the renal cortex volume, the total kidney volume, and the renal sinus fat at procedure and at 18 months average follow-up. 17 patients met our criteria. Out of those 17, 88% of them were females, 70% were white with an average age of 49 years old. Our results show a statistically significant decrease in BMI, renal sinus fat, creatinine, and GFR. We observed only a numerical decrease in the renal cortex volume and total kidney volume. We also found a positive correlation between the renal sinus fat volume and the total kidney volume. We believe these findings suggest the possibility of fat infiltration inside the kidney. An interesting finding is the correlation between estimated GFR and the differential of the renal cortex volume pre and post surgery. These results show us an improvement in the estimated GFR with a concomitant decrease of renal cortex volume. We can conclude in our study that bariatric surgery has demonstrated to be an effective treatment for severe obesity that results in improvement of comorbidities such as chronic kidney disease. Our results suggest that at 18 months average follow-up, we achieve a statistically significant improvement of the GFR, possibly via reduction in the renal sinus fat and organ fatty infiltration in the renal cortex. Thank you.